There are moments in life that split everything into before and after, the kind of moments where you realize that what you thought you knew was only the surface of something much deeper, much more complicated, and much more personal. I had one of those moments not in a hospital, not in a medical journal, not during a conference with colleagues. I had it standing in my parents' kitchen, holding my phone, listening to my father's voice crack on the other end of the line as he told me he had just come home from the pharmacy. He had gotten a vaccine that afternoon. Routine, the pharmacist said, totally routine for someone his age. And when he told me which one it was, I felt something drop in my chest. Not panic, not anger, something quieter and colder than either of those. The feeling of knowing that someone you love was almost failed by a system that was supposed to protect him. That moment changed how I practice medicine, and it is the reason I am sitting here making this video for you today. My name is Dr. James Whitfield. I have been a physician for over 2 decades with a background in internal medicine and geriatric care. I have spent the better part of my career studying how the aging body responds to medical interventions, including vaccines. And I need to be absolutely transparent with you before we go any further, because what I am about to say is going to be misunderstood by some people, and I want to get ahead of that right now. I am not anti-vaccine. I want you to hold that statement in your mind for the entire length of this video. Vaccines are one of the most important and life-saving developments in the history of human medicine. I have administered them. I have defended them. I believe in immunization as a cornerstone of public health. Smallpox is gone because of vaccines. Polio is nearly eradicated because of vaccines. Millions of people are alive right now who would not be if vaccines had never existed. That is not a debate. That is a fact. But here is the other fact, the one that gets talked about far too rarely in the spaces where everyday people can hear it. Not every vaccine is the right vaccine for every person at every stage of life. And once a person crosses the threshold of 60 years old, the medical calculus changes in ways that most people, including many physicians who are not specialists in geriatric medicine, do not fully appreciate. This video is about 5 specific vaccines that I, as a physician with over 20 years of experience, and as a son who has sat at his parents' kitchen table having the kinds of conversations that most families never have, would not allow my own mother and father to receive. Not because vaccines are dangerous in general, but because these specific vaccines, when given to adults over the age of 60, carry risks that are often not communicated clearly, if they are communicated at all. I want you to stay with me through all 5 of these. Some of them are going to surprise you. Some of them are vaccines that are routinely offered to older adults in clinics, pharmacies, and travel medicine centers across the country. And by the time we get to the end, you are going to understand not just what these vaccines are, but why the aging immune system responds to them differently and what you should ask for instead. Let us start there, actually. Let us start with the immune system, because everything I'm about to tell you makes more sense once you understand what is happening inside your parents' bodies as they age. The immune system is not a static thing. It is a living, dynamic network that is constantly changing, constantly adapting, and as we get older, constantly declining. The scientific term for this process is immunosenescence. It is a long word for a straightforward concept. As we age, the immune system becomes slower, less precise, and less powerful. The thymus, which is the organ responsible for training certain critical immune cells, begins to shrink in our 20s and continues shrinking throughout life. By the time a person reaches their 60s and 70s, their thymus may be functioning at a fraction of what it once was. The result is a body that responds to pathogens and vaccines differently than it did at 30 or 45. This matters enormously when it comes to live vaccines. And as you are going to notice very quickly, live vaccines are at the heart of almost every concern I am going to raise today. A live attenuated vaccine contains a weakened but still living form of a virus or bacterium. The idea is that this weakened pathogen will trigger an immune response strong enough to build lasting protection without actually causing disease. In a young, healthy individual with a robust immune system, this works beautifully. The immune system encounters the weakened pathogen, neutralizes it, and remembers it. Done. but in a person over 60 whose immune system is operating in a state of gradual decline, that same weakened pathogen can behave in unpredictable ways. The immune system may not neutralize it efficiently. The pathogen may replicate more than intended, and the line between a vaccine doing its job and a vaccine causing real harm can become dangerously thin. Keep that in the back of your mind as we go through each of these 5 vaccines. It is the thread that ties almost everything together. The first vaccine I would never let my parents receive after the age of 60 is the live attenuated influenza vaccine, commonly known by the brand name FluMist. This is the nasal spray version of the annual flu vaccine, and it has become increasingly popular in recent years precisely because it does not require an injection. You simply spray it into each nostril and you are done. No needles, no discomfort, no fuss. For parents who are anxious about shots or for busy caregivers looking for a quick option, it sounds ideal. But here is what the marketing does not tell you and what too many pharmacy technicians and even some general practitioners fail to communicate clearly. FluMist contains a live virus. It is attenuated, meaning it has been weakened, but it is still biologically alive and capable of replicating inside the human body. The FDA has already determined that this vaccine is not approved for anyone over the age of 49. That is not a gray area. That is a regulatory boundary based on evidence about how older immune systems respond to live influenza virus. And yet I have spoken with patients, real patients with real names and real families who received this vaccine at 68, at 73, at 79. Not because anyone was being careless or malicious, but because in the rush of a busy pharmacy or a packed clinic, the age screening did not happen. The question was not asked, the box was checked, and the spray was administered. What can happen when a person over 60 receives a live influenza vaccine? The consequences vary. Some individuals experience prolonged flu-like illness, symptoms that last not a few days but several weeks. Some develop respiratory complications that require medical intervention. Some, particularly those who are already immunocompromised due to conditions like diabetes, kidney disease, autoimmune disorders, or medications that suppress immune function, face risks that are genuinely serious. And the thing that makes this so frustrating is that the fix is so simple. There are excellent inactivated flu vaccines specifically formulated for older adults. The high-dose flu vaccine contains 4 times the antigen of a standard flu shot, giving the aging immune system a stronger signal to respond to. The adjuvanted flu vaccine uses an immune-stimulating ingredient to boost the body's response. Both of these options are not just acceptable alternatives, they are genuinely superior options for adults over 60, with clinical data showing meaningfully better protection in older populations compared to standard flu vaccines. So the message here is not that your parents should skip their annual flu vaccine. It is that they should receive the right flu vaccine, one designed for where their immune system actually is today, not where it was 30 years ago. If anyone ever offers the nasal spray to a parent or grandparent over 60, that is a conversation that needs to happen immediately. The second vaccine on my list is one that I suspect some of you have already encountered, either personally or through your parents. It is the original shingles vaccine, Zostavax. If your parent received a shingles vaccine any time before approximately 2020, there is a meaningful chance that what they received was Zostavax. And I want to talk about why that matters even now. Zostavax was a live attenuated vaccine. It used a weakened form of the varicella zoster virus, the same virus responsible for childhood chickenpox that lies dormant in nerve tissue for decades and can reactivate in older adults as shingles. For years, Zostavax was the only shingles vaccine available, and doctors administered it because having some protection against shingles was better than having none. I understand that reasoning. I would have made the same calculation. But the problems with Zostavax in older adults were significant and well documented. Efficacy was the first issue. Clinical studies showed that Zostavax's effectiveness dropped dramatically with age. In adults in their 50s, it offered reasonable protection. By the time you reached adults over 70, efficacy had fallen to somewhere between 30 and 40%. and in adults over 80, studies suggested efficacy as low as 18%. A vaccine that is 18% effective is essentially not doing the job we need it to do. The second issue was the live virus problem I described earlier. In older adults with compromised immune systems, whether due to age alone or to underlying health conditions and medications, a live varicella-zoster vaccine carries a non-trivial risk of causing vaccine-strain viral disease. There were documented cases of patients developing shingles-like rashes and neurological complications that were traced back to the vaccine rather than natural viral reactivation. The good news is that Zostavax has been discontinued. It has been replaced by Shingrix, a recombinant non-live vaccine that represents a genuine leap forward in vaccine science. Shingrix does not contain any live virus. Instead, it uses a specific protein from the surface of the varicella-zoster virus, combined with a powerful adjuvant system to generate immune protection through an entirely different mechanism. The results are remarkable. Clinical trials have demonstrated over 90% efficacy against shingles, even in adults over 70, and that protection appears to be far more durable than what Zostavax ever provided. I actively encourage every adult over 50 to get Shingrix, and I encourage their families to make sure it happens. Shingles is not just uncomfortable. In older adults, it can cause postherpetic neuralgia, a condition involving severe chronic nerve pain that can persist for months or years after the rash resolves. It can affect the eyes and lead to permanent vision damage. It can trigger complications involving the nervous system that are genuinely debilitating. The right shingles vaccine can prevent all of that. Just make sure it is the right one. Now we move into territory that is somewhat different. Territory that involves travel medicine and the very particular risks that arise when older adults decide, entirely reasonably, that retirement is the time for the adventures they spent decades dreaming about. The third vaccine I would refuse for my parents after 60 is the yellow fever vaccine. Yellow fever is a serious viral disease transmitted by mosquitoes in parts of sub-Saharan Africa and tropical South America. The vaccine against it is one of the most effective ever developed, with a single dose providing what appears to be lifelong immunity for most recipients. For travel to endemic regions, many countries require proof of yellow fever vaccination as a condition of entry. So when a 68-year-old woman walks into a travel clinic before her trip to the Amazon and the physician says she needs the yellow fever vaccine, that recommendation is not coming from nowhere. It is coming from a real set of requirements and a real disease risk. But here is what that conversation often fails to include. The yellow fever vaccine is a live attenuated vaccine, and the CDC, which is not known for alarmist language, explicitly acknowledges that adults 60 years of age and older face a significantly elevated risk of serious adverse events from this vaccine. The specific condition I want you to know about is called yellow fever vaccine-associated viscerotropic disease. It is a rare but devastating syndrome in which the vaccine virus escapes the immune system's control and causes a systemic infection that mimics the actual disease. It can affect the liver, kidneys, heart, and multiple organ systems simultaneously. And the fatality rate for individuals who develop this condition is staggeringly high, with some studies suggesting that more than half of affected individuals do not survive. I want to be precise here. This condition is rare. The absolute risk is low, but the risk increases meaningfully with age, and it increases further when underlying health conditions are present, which is true of most people over 60 to at least some degree. When you are working in medicine and you see a risk profile like this, one where the adverse event is rare but catastrophic, where the risk increases predictably with age, and where the population in question is already more medically vulnerable than average, that changes how you counsel patients. My recommendation for families navigating this situation is this. If an older parent or grandparent is planning travel to a yellow fever endemic region, the conversation should not start with which vaccine to give. It should start with a thorough, individualized assessment of their health status, their immune function, their current medications, and the specific conditions of the trip. In some cases, a medical exemption from the yellow fever requirement is obtainable. In some cases, modifications to the itinerary can reduce exposure risk. And in some cases, the honest conclusion is that this particular trip carries risks that are not justified for this particular person. That is a hard conversation, but it is the right one. The fourth vaccine on my list follows a similar logic, and it is one that comes up frequently in the context of travel medicine. It is the oral typhoid vaccine, sold under the brand name Vivotif. Typhoid fever is a bacterial illness caused by Salmonella typhi, and it remains a genuine health threat in many parts of South Asia, Sub-Saharan Africa, Central America, and other regions. For travelers heading to high-risk areas, typhoid vaccination is often recommended. There are two forms of the typhoid vaccine. One is an injectable vaccine using inactivated killed bacteria. The other is Vivotif, an oral vaccine taken as a series of capsules over several days, which contains a live attenuated strain of Salmonella typhi. And if you have been following the thread of this video, you already know why that distinction matters enormously for someone over 60. The oral typhoid vaccine introduces a live bacterium into the gastrointestinal system. In a young, healthy traveler with an intact immune system, this is generally well tolerated. But in older adults, the picture changes in several important ways. Gastrointestinal side effects from the live vaccine tend to be more pronounced and more prolonged. The vaccine has documented interactions with certain antibiotics and antimalarial medications, which are often prescribed in combination with typhoid vaccination for international travel, and older adults are far more likely to be on medications that fall into these interaction categories. And the existing data on Vivotif's efficacy in older populations is notably thinner than what we have for younger age groups, meaning we are making recommendations based on incomplete evidence. The injectable typhoid vaccine, by contrast, uses killed bacteria and does not carry the same risks. It requires a single injection rather than multiple capsules. It has a stronger and broader evidence base across age groups, and it sidesteps the live organism concern entirely. It is not a perfect vaccine, and no typhoid vaccine offers complete protection. But when choosing between a live oral vaccine and an inactivated injectable vaccine for a person over 60, the injectable version is the clear preference. What I want you to take away from this is not just the specific recommendation, but the broader habit of questioning. When a travel medicine clinic presents your parent with a list of recommended vaccines, that list was not always written with 65-year-olds or 72-year-olds in mind. Much of the baseline vaccine guidance in travel medicine was developed with adult populations broadly defined, and older adults with age-related immune changes and multiple concurrent health conditions often occupy the edges of what the research actually captured. Push for individualized guidance. Ask specifically about age-related risk profiles. Ask whether each recommended vaccine is live or inactivated. These are not difficult questions, and any good travel medicine physician should welcome them. And now we arrive at the fifth vaccine, and I want to approach this one carefully because it operates in a somewhat different space than the others. The fifth vaccine I would not allow for my parents after 60 is the BCG vaccine, Bacillus calmette-guerin, which is the primary vaccine used against tuberculosis. In the United States and most Western countries, BCG is not part of the routine childhood or adult vaccination schedule, but globally, it is one of the most widely administered vaccines in history, given to billions of children at birth in countries where tuberculosis remains a major public health burden. The situations where an older adult in a Western country might encounter a recommendation for BCG vaccination include extended travel to high-burden tuberculosis regions, certain occupational settings involving close contact with tuberculosis patients, and more recently, experimental research contexts exploring BCG's potential effects on the aging immune system and its possible role in other conditions. BCG contains a live attenuated strain of Mycobacterium bovis, a bacterium closely related to the one that causes tuberculosis. And here is where the risk profile for older adults becomes significant. In young, healthy individuals, BCG is generally well tolerated, But in individuals with compromised immune systems, whether due to age, medications, HIV, or other conditions, a live mycobacterial vaccine can cause a condition called disseminated BCG disease, in which the live bacteria from the vaccine spread beyond the injection site and establish infections in multiple organ systems. The symptoms include persistent fever, weight loss, swollen lymph nodes, and infections in the liver, lungs, or other tissues. Treatment requires months of anti-tuberculosis drug therapy, regimens that are difficult to tolerate and that carry their own risks, particularly for aging kidneys and livers. The risk of disseminated BCG disease is low in the general population, but climbs substantially in older and immunocompromised individuals. And because most adults over 60 have at least some degree of immune compromise, whether recognized or not, this vaccine deserves extreme caution in this age group. If tuberculosis exposure is a genuine concern for an older adult, whether due to travel, occupation, or close contact with an infected individual, there are alternatives to BCG that do not involve introducing a live organism. There are preventive medication protocols. There are regular screening approaches using skin tests or blood tests. There is the option of simply not placing oneself in prolonged high-risk exposure situations. None of these are as elegant as a single injection, but for someone over 60 with the immune profile that age brings, they are meaningfully safer than a live bacterial vaccine. Now, I want to step back from the individual vaccines and talk about something larger, because I think the individual details only matter if they sit inside a framework that makes sense to you. We are living through a moment of intense polarization around vaccines, and I think that polarization is making it harder, not easier, for everyday people to make wise decisions about their family's health. On one end of the spectrum, there are voices saying that vaccines are categorically dangerous, that they are part of some malevolent design, that no one should ever receive any of them under any circumstances. These voices are wrong. They are spreading information that costs lives, and they deserve no platform in serious conversations about medicine. But on the other end, and this is the part that I think gets less attention, there are voices, including well-meaning voices within medicine itself, that treat vaccine recommendations as though they are one-size-fits-all truths that apply equally to every human body at every age. And that framing is also wrong, though the harm it causes is less dramatic and therefore less visible. The harm it causes looks like a 73-year-old man getting a nasal spray flu vaccine he was never supposed to receive. It looks like a 68-year-old woman getting a travel vaccine whose risk profile for her age group was never explained to her. It looks like families who trusted without asking and were failed not by malice, but by inattention. Good medicine has never been about applying universal rules without thinking. Good medicine is about looking at the individual in front of you, or in this case, the parent you are trying to protect, and asking what is right for this person at this age, with this health history, in this specific situation. That is what I am asking you to do. Not to reject vaccines, not to distrust your parents' doctors across the board, but to show up as an active, informed participant in their healthcare, to ask questions, to understand the difference between live and inactivated vaccines and why that difference matters for aging immune systems, to know that high-dose and adjuvanted flu vaccines exist and are specifically better for older adults, to know that Shingrix replaced Zostavax and that if your parent only received the old vaccine, their protection may be inadequate and they should speak to a physician about getting the updated series, to know that when travel medicine is involved, age-specific risk conversations are not optional. They are essential. If you go to your parent's next medical appointment and you simply ask, is this a live vaccine, and what are the specific risks for someone of their age, you will have accomplished something meaningful. You will have shifted the dynamic from passive acceptance to active engagement. And in my experience, that shift changes outcomes. I also want to say something to those of you who are watching this and feeling a knot of worry because your parent has already received one of the vaccines I mentioned. Please hear this clearly. Feeling guilty about past decisions made with incomplete information is not useful to you or to them. The fact that you are here watching this, trying to learn more, is itself an act of love. Most adverse events from these vaccines, when they occur, do not happen to everyone, and they are often manageable when caught and addressed. If you have concerns about a vaccine your parent has already received, the right move is a calm conversation with their physician, not panic. What matters now is what you know going forward. And going forward, you know to ask about live versus inactivated vaccines. You know that the high-dose flu vaccine and adjuvanted flu vaccine are the right choices for people over 60. You know that Shingrix is dramatically superior to Zostavax and that every older adult should have it. You know that yellow fever and oral typhoid vaccines carry elevated risk profiles for older travelers that deserve explicit, individualized discussion. And you know that BCG vaccination in immunocompromised or older adults requires careful scrutiny. That knowledge belongs to you now. Use it. I want to close by telling you what I tell my own parents. I tell them that my job as their son is to make sure that the medical system, as good as it is in many ways, does not fail them through inattention or through the application of guidelines designed for populations that do not include 70-year-olds with the specific medical histories they carry. My job is to ask the questions they might not know to ask. My job is to translate the complexity of medicine into information they can actually use. And your job, if you are watching this as someone with aging parents or grandparents, is the same. You do not need a medical degree to do it. You need curiosity. You need the willingness to speak up in a clinical setting. And you need the knowledge that asking questions about your family members' care is not rude or distrustful. It is exactly what good family advocacy looks like. The healthcare system works better when patients and families are engaged. The doctors and nurses and pharmacists who are doing their jobs well will welcome your questions. They will take time with you. They will explain their reasoning. And if you ever encounter someone who reacts to your questions with dismissal or impatience, that reaction tells you something important about whether that person should be the one making medical decisions for someone you love. Take notes. Ask questions. Do not assume that routine means right for everyone. And remember that aging bodies deserve not just care, but the specific, thoughtful, individualized kind of care that takes their age seriously. Your parents gave you everything. The least we can do is pay attention. If this video gave you something valuable, something you are going to carry into a conversation with your parents or their doctor, I want to ask you to do 3 things. First, leave a comment below. Tell me which of these 5 vaccines surprised you the most. Tell me if you have had an experience with one of them in your own family. Your comments help other people find this information, and they help me understand what topics matter most to you. Second, subscribe to this channel. I make videos about health, medicine, and aging with the same goal every single time: to give you the kind of honest, nuanced information that helps you protect the people you love. And third, share this. Share it with your siblings. Send it to your parents. Post it where the people in your life who have aging family members will see it. The information in this video only helps if it reaches the people who need it, and you have the ability to make that happen right now. Thank you for being here. Thank you for caring enough to watch this all the way through. I will see you in the next video.